lots of knowledge in various health subjects, and we're happy that Dr. Ruff, Gabrielle Ruff, is part of our church. She did her medical school at The Ohio State University, and then did her internal medicine training at SUMA, and then stayed on and specialized in doing geriatric fellowship. She's a geriatrician. She's also program director for the geriatric fellow at SUMA, and heads the program for geriatrics and geriatric fellow. So we're happy she's here, and without wasting much time, I'll invite her to start the conversation.
Happy Sabbath, everyone. I'm going to use this both for my notes and just my security blanket, so give me a second here. All right. I'm so glad nobody forgot that we were having this lecture. Thank you so much for showing up. I wanted to do a title that was a little catchy, so forgetting what you don't remember, it is actually a running joke that I have with many of my patients. I'll ask them, like, well, tell me, they'll say, yeah, I'm having trouble with my memory. And I'll say, well, tell me what you're not remembering. And they're like, I don't remember. So it's a just running joke in our clinic. Really, the goal of this talk is to help you understand a little bit about how memory can change as we get older, and also what the resources are and things that you can do to navigate that process. Next slide, Mr. Potts. All right, woo. When I did this, it definitely did not seem like it'd be that small. So this is our agenda. We're going to talk a little bit about the statistics on aging. Then we're going to go into the physiology of memory, disorders of memory, diagnosing dementia, managing dementia, prevention, and then some frequently asked questions, and then we'll go through our summary. Next slide, please. All right, so I put this in because I think it's worth noting that due to events that started long before any of us were born, the life expectancy of the average human has decreased exponentially since our forefathers, Adam and Eve, were alive, and Methuselah was, I believe, the oldest man who lived at that time, and he was 969 years. And you can just see that as we've progressed through time, our life expectancy has decreased. Abraham lived to be 175, Moses 120, David was about 70, and currently the life expectancy, at least as of 2021, was about 76.4 years for the average human. Next slide, please. I apologize for turning my back to you, but it's much easier for me to see this. So this is, again, just a slide looking at a life expectancy. What you can see is life expectancy actually decreased between 2020 and 2021. I have to believe that COVID had something to do with that, but in 2021, life expectancy for both sexes was 76.4, as we talked about earlier. For men, 73.5. For women, we lived just a little bit longer, 79.3. Next slide, please. And this is looking at the top 10 causes of death in the U.S., and you can see that Alzheimer's disease is on there. It's worth noting that some of these diseases that are here kind of run together. We call them comorbidities, meaning if you have one of these, it's possible you may have another one. For instance, if you have heart disease, you're at risk for having a stroke. If you have diabetes, you're at risk for having heart disease and a stroke. So some of these things do kind of seem to be present in the same individual, and some of them are risk factors for some of the other diseases here. Next slide, please. So we're going to talk about the physiology of memory as we get older. One of the things that I often hear in my clinic is, oh, he's just getting older, or she's just getting older, when someone comes to me with a memory concern. So I think it's really valuable to know what normal changes in memory look like as we get older versus abnormal changes in memory. So these are normal changes of memory as we get older. We may notice that there's a decreased capacity of working memory, and working memory is kind of your ability to hold information in your brain for a short period of time, right? Someone gives you a phone number, you don't have a pen, you don't have paper, you don't have a phone, so you're trying to remember that number till you can get someplace to store it. That's what your working memory is helping you do, right? Or you're like, oh, I'm just gonna run to the store and get 3 items. You always only remember 2, but your working memory helps you remember that. So it's kind of like short-term storage. Decreased episodic memory, so remembering events. That may get a little harder as we get older. Change in semantic memory. So semantic memory is our knowledge of the world, right? Like semantic memory is how I know that's a piano, that's a chair, this is a music stand. So as people get older, they may just find themselves struggling a little bit more to find the word that they want. And then decline in memory retrieval. So it's not that as we get older, we don't make new memories, we just have a little harder time accessing them. Next slide, please. We may also notice a decline in processing speed. I will say, though, that there are some compensations that our body does to account for some of these changes in memory. There's an increase in crystallized intelligence, and crystallized intelligence is really based on kind of general knowledge that you already have, like things that you've already established that you know well. And so sometimes that actually can increase as we get older. Also, our brain recruits neural pathways to compensate for some of the changes of memory. Next slide. So again, going back to the concept of being able to differentiate normal memory loss or normal memory changes in aging from something that is abnormal, we have this slide. So if you look at the left here, normal aging, we do see a mild decline in memory. We just talked about that. We do see that there may be more effort or time needed to recall information. You know, new learning may be slowed, but you can compensate using calendars and lists. You may feel that you're a little less efficient when you have to split your attention and try to multitask and do things kind of all together. But the most important thing here, and that's why I circled it, is there is no impairment in social and occupational functioning. So someone who has memory loss that is normal for getting older does not have an impairment in function. They are not forgetting how to pay their taxes. They are not getting lost when they drive in familiar places. They are still functioning very normally and safely in the world. We then move on to mild cognitive impairment, and we're going to talk a little bit more about that in another few slides. But this is where there is memory loss that the person can notice, and sometimes their family members or people that are around them can notice too. It's going to be in at least one of the cognitive domains, so memory or executive function or language or kind of visual spatial perception, how they see the world in space. We test for these things in our clinic using a variety of cognitive assessments. For instance, visual spatial perception, we have someone draw a cube, and that kind of helps us understand how they see the world in space. We sometimes also have them draw a clock, which helps us understand how they see the world in the space, and a little bit of executive function. You will learn a lot about someone if you watch them draw a clock. It tells you about their ability to plan out the clock, the layout of the clock, and follow the directions. So someone with mild cognitive impairment may struggle with some of those. There are people that primarily have just memory as their symptom of mild cognitive impairment. So again, it's noticeable and it's measurable. So when this individual comes into my clinic, I can see on their testing that they're not scoring what I would expect for their age and level of education. However, once again, there is no impairment in social and occupational functioning. Function is very important when we're looking at memory and we're looking at individuals with memory loss. So now on the right, we have Alzheimer's dementia. So with this individual, you will see significant decline in memory, and that's going to be, again, in one or more cognitive domain, executive functioning, language, visuospatial ability, perceptual motor ability. And this decline is usually steady and progressive. It interferes with independence in everyday activities, and other medical and psychiatric conditions, including delirium, have been excluded. So that's just saying that before we diagnose someone with Alzheimer's dementia, we need to make sure that there's not something going on that could mimic dementia, like being confused because they have an infection or being on a medication that can cause memory loss. Again, though, the key here is function is impaired in dementia. So this is someone that they may not always notice the changes that their memory loss is causing, but other people around them will notice, especially as it continues to progress. Next slide, please. So now we're going to talk about disorders of memory. We talked about what memory loss that's normal for getting older looks like. Now we're going to talk about memory loss that is abnormal. And just a little bit more on mild cognitive impairment. This is essentially an intermediate stage between normal cognition and dementia, we now know. Again, the memory loss is there, but function is maintained. For some people, this can be a precursor to dementia. Not everyone with this diagnosis will go on to develop dementia, but some people will. For other people, this condition is reversible. If their cognition is impaired because they have untreated depression. If we treat the depression, sometimes the memory gets better, the mild cognitive impairment improves. If it's a medication effect, I have one patient that was taking a benzodiazepine, and he came in and tested low enough on his cognitive assessment that I actually thought he did have dementia. And then his psychiatrist took him off of that medication, and I saw him 3 months later, and his score was normal. So medication should never be underestimated as a potential cause of memory change. So again, he would be an example of someone who we changed the medication, his memory got better. And then recovery from an illness, being in the hospital, having had a big surgery or an infection, a long stay in the ICU, that can definitely impact the memory. And usually as someone comes out of that, goes home, starts to recover, we may see a change in their memory and an improvement. Next slide, please. Oh, good gracious. It was so pretty on my computer. It is barely visible up here. Essentially, though, I think I remember what this slide says, the genetics of dementia. So we have two different kind of time frames for dementia. If it happens before 60, we call it early onset. And then there's late onset dementia. And on the bottom there, for late onset dementia, there are certain genes that actually increase your risk of developing dementia. It's the ApoE gene. There's 3 and 4, and I believe if you have both genes for 4, Dr. Ganta can correct me if I'm wrong, I believe that increases your risk of developing Alzheimer's dementia. Next slide, please. So why do we talk about this? I oftentimes meet patients who I think they hate coming to my office, which is totally understandable, because they feel like I'm trying to give them a label, right? As we age and we change as individuals, it does feel like society's always trying to give us labels, right? Like as women, we can no longer have children at a certain age, so that's, another label, and it feels like everyone is trying to label us. But that is not what we try to do when we diagnose people with dementia. First and foremost, dementia has a huge impact on the healthcare system and the individual with dementia and the people who love them and are in their environment. So, annually, $1,818 billion are spent for the direct cost of medical and social care and informal care. Medicare, Medicaid, private insurances, they provide much of the direct cost, and the remaining costs come from families and or caregivers. So what insurance doesn't cover for dementia care, families and caregivers are covering, and that's about $230 billion in the US. So this is not a small thing. This is not a small financial impact. This is very impactful on families. And I interact with families every day, and it sometimes breaks my heart because they're in a spot financially where insurance won't cover the care that they need for their loved one, but they don't have the money to give their loved one like the care that would probably be ideal. And it's very challenging, and people oftentimes feel hopeless in these situations. There's an emotional toll too, obviously on the individual that is being diagnosed. One of the questions in our clinic when we're talking to caregivers is, how do you think your loved one would react to knowing that this could potentially be dementia? If we say that word, how do you think they will take that? Because there's such a stigma tied to this in this country that there are some people that are just devastated to get that diagnosis. And then caregivers, I consider the caregiver of my patients with dementia my patient also, because if I can support them, the more that I can give them support, the better they'll be able to take care of the patient. But caregivers are at risk for psychological distress, depression, and they can have more physical health issues as well. So dementia is a very, very important disease. It's important to identify it early. Something else that's important to know about dementia is it increases your risk of having a bad outcome in the hospital. If you have a diagnosis of dementia and you go into the hospital, you're at a higher risk of getting confused from being in the hospital, getting confused if you have an infection. So again, identifying it is not about labeling someone, it's about making sure that we can optimize your life and make sure that we keep you safe in environments that might be a threat to you because you have a diagnosis of dementia. Next slide, please. So what is dementia? I get this question a lot, which is a great question. The very technical definition is it's a decline in cognition in one or more of the following areas, and we touched on this a little earlier. Learning and memory, language, executive function, complex attention, perceptual, motor, social cognition. And it also represents a decline from baseline, and it has function implications. So we can see the impact in someone's function day to day if they have a diagnosis of dementia. Really important to know, dementia is not inherently a part of normal aging. Everybody does not get dementia as they get older. Next slide, please. So this is a really helpful visual aid that I'm glad that I found, because sometimes there's a confusion about, is dementia Alzheimer's, is Alzheimer's dementia? So dementia is an umbrella term. It is a general term that means you have memory loss that's impairing your ability to function. I tell people it's very similar to if you ask me, do I have a car? Yes, I have a car. Car is a generic term for a mode of transportation that has 4 wheels, a steering column, and a couple of seats. But it doesn't tell you what type of car I have if I just tell you I have a car. Conversely, just saying that someone has dementia doesn't let someone know what type of dementia they have. Dementia, again, is the umbrella term under which many different types follow. When I was in training, I was taught that there are over 100 different types of dementia. So it's very possible for someone to have a dementia diagnosis that is unspecified. We know it's one of those 100 types, we're not sure exactly which one. Under the umbrella are the 4 more common types that we see: Alzheimer's disease, frontotemporal dementia, Lewy body dementia, and vascular dementia. And I think my next slide goes into this a little bit more. And it's so tiny, sorry. So Alzheimer's, we're gonna talk about that a little bit more in detail, but I just kind of wanted to put up another visual looking at the 4 more common types of dementia. Next slide, please. So Alzheimer's, onset of Alzheimer's is gradual, which is probably why a lot of people just mistake the symptoms for normal aging. A lot of times when I've talked to families for someone that I've diagnosed with Alzheimer's, they kind of start to think back over the years and realize there were symptoms. They were just subtle because it's a gradual process. It doesn't come on suddenly. It gradually progresses over the years. So I've actually changed how I've asked people about memory, because a lot of times when I ask caregivers, like, did you see anything? They're like, oh no, they were always sharp. They were great for fill in the blank age. So I've started asking them, what did you notice over the past years, no matter how subtle, and even if you just assumed it was normal for getting older? And that's usually a way to kind of get some more information out of the caregivers regarding what symptoms they notice. In someone with Alzheimer's, you'll see memory impairment as the primary feature. There'll be difficulty learning new information. You'll also see difficulty with language and visual spatial cognitive domains. There are motor symptoms with Alzheimer's disease, but they're usually a much later stage finding. Later stage Alzheimer's, you may see that people start to lose the ability to use things, like figure out how to use a toothbrush or what to do with a fork, a knife, and a spoon, but that's a later stage finding. And I meant to say this at the beginning, because there's so many different types of dementia, this is gonna be a very broad overview of the main types. I was thinking to myself, I probably should have just picked one to go over, but we're gonna just do a broad look at it today. So in mild stage Alzheimer's, someone may get lost. They may go for a walk and not remember how to get home. They may go for a drive and not remember how to get home. Moderate stage, people may start having trouble recognizing friends and family. Behavior may become more impulsive. Severe stage, communication can actually become impaired. Next slide, please. This is just a little bit of the pathology of Alzheimer's dementia. So if you see on the right side of the screen there, we have a neuron, that little purple and blue picture there. So the neuron, our brain is an electrical conduction system, and that neuron actually is insulated, just like you would see like a telephone wire insulated, and that's kind of how information travels through the brain. What Alzheimer's does is it deposits abnormal proteins onto the neuron, which interfere with the neuron's function. And the clinical term is it causes plaques and tangles. So amyloid plaques, amyloid is the type of protein that is deposited onto the neuron, and then tau proteins cause the tangles throughout the brain. There are newer lab tests for Alzheimer's, and when I say for Alzheimer's, I mean newer lab tests that can support a diagnosis of Alzheimer's. There are some biomarkers in the blood that we are now looking at that actually can measure the tau and the amyloid proteins. They're not the best test to use. The cerebrospinal fluid is still going to be much more specific and sensitive for these proteins. However, it's a lumbar puncture, which is an invasive test, so we don't necessarily want to do that for everyone unless we have a really good reason to. Again, imaging is not diagnostic, but it gives you information that helps to support a diagnosis if you're already suspicious. What you can see is shrinking in the brain. Specifically, the hippocampus can shrink. There's a certain type of PET scan that will actually show you the amyloid protein. And then there's another type of PET scan that will show that there are areas of the brain that have decreased metabolism in the areas that are affected by Alzheimer's. Neither of these images are standard of care currently for assessing someone for Alzheimer's. Next slide, please. So frontotemporal dementia is one of the more rare types of dementia. What's unique about it, though, is it is, because of the location of the damage to the brain, it's someone who is sometimes very inappropriate. Sometimes you can figure out who this person is because they say the thing that like maybe everybody's thinking but nobody would say out loud. Sometimes families are very stressed by this because you can't take someone like that in public because you don't know what they're going to say. I remember being a resident and walking past a room, and I heard a patient commenting very loudly on the physical attributes of his nurse. And I was like, oh, interesting. And I could hear him walking to the door, and I already knew like where his bandage on his head was gonna be. So when he came out, he had a big bandage over the front of his head here because he'd had an injury to his frontal part of the brain, which is where his executive function is, which is why he had no filter and was just saying whatever he saw and thought. This is often what we see in patients with frontotemporal dementia. And sometimes that's a little bit more than the memory component, which makes it a little tricky to diagnose, which is why it says here plus or minus memory. Sometimes what you see more are just the behavioral aspects of it. Next slide, please. So there's a second slide for frontotemporal dementia, and I put them out of order. So next slide, and then we'll go back, Bob. And one more slide. Yes. So in frontotemporal dementia, usually lab tests are normal. There are not really any tests that are going to point to this per se. You can see atrophy. Again, it's frontotemporal dementia, which is the area of the brain that's impacted. So you can see shrinking in that part of the brain. And if you do that PET scan that looks at brain metabolism, you will see decreased metabolism in the frontal and temporal parts of the brain. I was a fellow and I saw a patient who had this, and it was very striking. She was in her 60s, and we'd given her the cognitive test, and it's out of 30 points. A normal score is 26 or higher. Her score was 3, which was incredibly low. And when I went to evaluate her, having a conversation with her was almost impossible. it was like I would say, "How are you doing?" And she was like, "Rabbits." There was no correlation between our communication. And her caregiver was her brother, and how he knew something was wrong is this is an individual who had been gainfully employed. She had had a good job and doing well, but she got in her car one day and went driving, I think, to the grocery store, and ended up in Kentucky and couldn't get back home. And she's from Ohio. So that was kind of the first thing that he saw that let him know that something was wrong. I think we actually did order this particular scan on her, and it did come back with the decreased metabolism in the frontal and temporal parts of the brain. So if we could just go back 2 slides, Bob. Okay. So dementia with Lewy bodies is another type of dementia we sometimes see. There can be memory symptoms. Also, there are visuospatial symptoms or hallucinations. So sometimes people complain of seeing like a little animal like run off in the periphery, or they see little like a squirrel or a mouse like running. That is sometimes a hallmark of this type of dementia, and usually the hallucinations precede the changes in memory. Someone who has this diagnosis will also look like a Parkinson's patient because there is a similar pathology there, so they can have some of the physical symptoms or findings that we would see in someone with Parkinson's, like the difficulty showing emotion on the face, trouble with walking, kind of slowed physical movements. So the cognitive decline here, someone may struggle to concentrate, they may have difficulty staying alert, their ideas may be disorganized or illogical, and again, this is the Parkinson's part, the movement problems, muscle rigidity, loss of coordination, reduced facial expression. They may also have trouble with sleep. Either they're sleeping too much or they're not able to sleep at night. And then we talked about the visual hallucinations. And this actually progresses faster than Alzheimer's. It's gradual, but it's a faster progression than Alzheimer's. Next slide, please. And again, it's another dementia that has abnormal proteins that are deposited in the brain. Next slide, please. And one more. Okay. So vascular dementia is another common type of dementia. It can sometimes be seen in conjunction with Alzheimer's dementia, and we'll talk about that in a little bit. But the kind of onset may be sudden, because usually what triggers this is someone had a stroke. So that's why the memory change can be sudden onset. The cognitive symptoms really depend on where the stroke was, what part of the brain lost blood supply. One of the things we sometimes notice is people may have a little slowing of their processing. Their brain may just not be quite as flexible. They may struggle with going back and forth between tasks in their head. And the progression is gradual or stepwise, but it's really based on how much further blood loss there is to tissue moving forward. Next slide, please. Usually for my patients with vascular dementia, if I get an MRI, I will see that they had a stroke, or I will see that they have a really high burden of areas of the brain that have lost blood supply. Maybe they didn't amount to a stroke that was clinically relevant, but they have enough areas of brain supply that have lost, or brain that have lost blood supply, that it actually is impacting their memory. Next slide, please. So mixed dementia. It is actually possible to have more than one pathology of dementia at the same time. And it's widely starting to be more and more thought that there's not so much pure Alzheimer's. A lot of what we're seeing is someone who has Alzheimer's and vascular dementia kind of mixed. And what's important to note is if someone has a mixed dementia, they are not going to progress exactly the way that you would think either of those dementias would progress by themselves, because now it's a mixed pathology, so that kind of changes what the progression of their dementia is going to look like. And next slide, please. Also worth noting that there are some atypical presentations of dementia. I think we see this a lot. It's very common to have a family member who's had dementia or have known someone and kind of feel like that is what's made you an expert on dementia. But the truth is no two people have the exact same progression of dementia, and that's important to note. We sometimes meet patients who are terrified when we give them a diagnosis because their mother had dementia and they remember what it looked like for her. And we have to tell them, this may not be what it looks like for you. So I also sometimes see that caregivers assume that dementia looks one way and it's just terrible, right? It's the person who can't remember anybody, just can't do anything. So if their loved one is not exhibiting that, they're like, oh, that can't be dementia. But the truth is dementia has stages and it can look different in different people. So just because someone doesn't look like severe stage dementia does not mean that it's not present. There are also some, I call them atypical presentations of dementia, where the first sign that someone has is a new psychiatric disorder. So someone in their 70s who's never really dealt with depression is now depressed or anxious or has a new onset bipolar disorder or psychosis. That can be the early sign of dementia that we see. And it's a little disconcerting to us, I'd say, as providers, and also to families, because it feels like it comes out of nowhere, right? As far as they know, this person was just fine up to this point, and then all of a sudden, they have this change in personality or this new psychiatric diagnosis, and now they're being told that there's a diagnosis of dementia, and it's a lot to process. There is a correlation between psychiatric diagnoses and increased risk of being diagnosed with dementia. Next slide, please. So how do we diagnose dementia? Next slide. So first and foremost, dementia is a clinical diagnosis. I think we are definitely moving towards a place in medicine where we will have a lot more like lab data and imaging data to support diagnoses. And will we ever get to the point where it's truly just a lab diagnosis? Maybe. But it's a clinical diagnosis currently, and again, function matters. Function is a part of our assessment for someone with dementia. So if you come, for instance, to my clinic, your dementia assessment is probably going to look a little bit like this. We're going to get detailed history about your medical diagnoses, any medications you're on, family history, substance use history. And again, we talked about medications as a potential for causing memory loss. Family history helps us understand your risk factors for dementia, and substance use is something else that can depress memory and mimic dementia. We will also ask questions about when do the symptoms start? How long do they last? Is there anything else that you're seeing, right? Someone has memory loss, are they also having hallucinations, or are they having trouble, remembering how to use the microwave? And also we'd like to know their baseline functional status and then how this new symptom is a change from that status. Then they'll have a cognitive assessment using a validated screening tool. There are many different tools. It just kind of depends on the practice, what tool that they use. I would say inevitably you will always draw a clock though. For whatever reason, most of the tools out there, you're drawing a clock. Also a physical exam. And usually the physical exam, I really focus on the neurologic exam because that's going to give me a little bit of information that may help point me in the direction of a diagnosis. We talked about the fact that people with Lewy body dementia can sometimes have symptoms that are similar to someone with Parkinson's. So doing a neurologic exam when I see someone in the office can help me determine if that might be also going on. We look at labs that are associated with reversible causes of memory loss. So vitamin B12. Vitamin B12 does not help memory if your vitamin B12 is normal. It just makes your urine very, very yellow. But if your vitamin B12 is low and we give you back vitamin B12, your memory may improve, which is why when someone comes in with memory loss, we do check their vitamin B12 level. We also look at their thyroid function. If your thyroid is underactive, that can actually cause slowed reactions. It can cause you to have trouble thinking, slow processing speed. So that's something else that could be reversible if we find it and treat it. We get imaging of the brain. We're looking for some of those changes that we talked about earlier that may support a diagnosis of dementia. And we're just looking at the structure of the brain to see if there's anything there that could be contributing to the memory loss that someone is reporting. And then now, I didn't do this in fellowship because these weren't available, but newer biomarkers in the blood or the CSF. I'm going to put Dr. Ganta on the spot. There you are. Are you using those? And did you use those in fellowship? Like the p-tau and the beta? That can be. Yeah. Thank you. Yeah, I absolutely. What she said, if anybody didn't hear her, is that she doesn't order them to diagnose anybody because there are better ways to diagnose dementia than sending someone for a lumbar puncture. But you may or may not have seen this in the news. There were some medications that came out probably about 1.5 to 2 years ago now that specifically attack amyloid. And we talked about amyloid as one of those abnormal proteins that gets deposited in the brain. So these medications specifically attack the amyloid and kind of, for lack of a better word, pull it off the neuron. So they decrease the amyloid burden in the brain. However, to be a candidate for this medication, you actually have to prove that you have the amyloid. And the best way to do that is with cerebrospinal fluid through a lumbar puncture. So she was saying that she only orders that if she thinks that someone is a candidate for one of those medications, because she needs to be able to prove to the insurance company that they do have the protein, so they will cover the rest of the treatment. Worth noting, those medications looked at patients over a span of about 1.5 years, and the study that came out that kind of allowed these medications to now be approved and put on the market showed that over 1.5 years, people with mild cognitive impairment or mild Alzheimer's had a slowing of progression of their symptoms by about 4 or 5 months. It's progress. It's definitely progress in an area where we need more continued research. When I talk to my patients, it's really up to them if they feel like that 4-month slowing of progression in a stage that's already pretty mild is worth it to them. I really let them make that decision because these medications are infusions. So someone does have to go in and sit for an infusion. There are some risks associated with them. One of the risks that they saw in the study was there's small hemorrhages, bleeding that happens in the brain. So there are serial MRIs of the brain that have to happen while you're on the medication. They did note that those got better when the medication was stopped. So again, that's a conversation, kind of what do we call it, shared decision making with myself and my patients about that, whether or not they feel that the benefit of this medication is outweighed by some of the risks and potential side effects. Some of the other things that we kind of delve into when we see someone in the clinic, we get information about how they're functioning in the world. Are they forgetting appointments? Are they having issues driving? So people are, by and large, very loving and very much want to protect their loved ones. So a lot of times I talk to caregivers and I ask if they have any trouble with driving. They're like, oh, no, they're fine. They're fine. So the question that actually pulls like the honest answer out of people is, would you let the grandchildren drive in the car with them? And then people are like, oh, no. So driving can't be fine if you wouldn't let the grandkids drive with them. But again, it's a natural human instinct to protect the people that you love. And so in the clinic, we're not trying to catch someone in any kind of mistruth. We're just trying to help them understand that we're trying to help their loved one. And total honesty is the best way to do that. People may notice that they're misplacing things, they get lost, missing bill payments. That's a big one. Sometimes we see people in the hospital because utilities have been shut off, because family didn't realize they just weren't paying the electric bill or the gas bill because they didn't remember that they had the bill. Personality changes are sometimes something that we ask about. People may struggle with the date, and also, how long has this been going on? Days, months, years, decades. We ask about the pattern from when a caregiver first started noticing the memory loss. And then ADLs and IADLs are activities of daily living and instrumental activities of daily living. So activities of daily living are things like going to the bathroom, taking a shower, putting your clothes on, eating, feeding yourself, walking around. Those are usually impaired later. If someone has a diagnosis of dementia, it's a later stage finding. Usually early in a diagnosis of dementia, those things are still pretty intact and someone is able to do them. So if I see someone in families telling me, they can't remember how to put their clothes on, or they don't remember the order that clothes go in, we're already looking at a more advanced stage of dementia, because that is a later stage finding. Usually where we'll see it earlier on is in the instrumental activities of daily living. And that's the things like paying the bills, remembering to take medications, going grocery shopping, driving, cleaning the house. We ask about home safety. Anytime someone comes with memory loss, our social workers ask about guns, because what you don't want is someone who has memory loss, hallucinations, and a loaded gun in the house. That is a very, very bad combination, and not something I've not seen before. So we do ask about home safety. We also ask about mood. Is someone having trouble eating? Are they having trouble sleeping? Are they just losing interest in things that they used to enjoy? And then again, we talked about this, any acute illnesses, thyroid problems. We're always looking for things that could mimic dementia, because we do want to make sure that we make the right diagnosis. Next slide, please. This is a very kind of broad overview of the staging of dementia. If you go online, you'll see very different kind of approaches to staging. It just kind of depends on what you look at. But early on, when someone has no cognitive impairment, everything's fine. Nobody sees anything, they're functioning fine in the world. Very early on, some people may actually notice that they're having changes in their memory. I will say that a lot of my patients with specifically Alzheimer's, one of the hallmarks of the diagnosis is they actually don't realize that they're having problems. I have a lot of patients that have no insight into the fact that they're having memory loss and just think their kids are overreacting, they're fine. But some people do actually, they can tell that something's changing. They may notice that they're having trouble finding the words that they used to know, they may lose things, but they're not really to the level that somebody else would notice. When we get to mild cognitive decline, this is now the level where somebody else is probably noticing. So this could be family, friends, coworkers, or even a medical professional. This is also the stage where we probably will catch it on the cognitive testing that we do. The memory loss will be measurable if we do a cognitive assessment. Moderate decline, now we see someone that may have some personality changes. They may be more subdued and withdrawn. Socially, they may be more subdued and not interacting with people as much. Next slide, please. Moderate severe, now we're seeing even more symptoms, and now someone's starting to have need assistance like we talked about with those activities of daily living, putting on their clothes, taking a bath. Severe cognitive decline, memories continuing to get worse, and they may need help essentially with everything. They may require total care. And then in the very severe cognitive decline or late stage Alzheimer's, people may lose the ability to talk, to swallow, to walk. There is a motor decline also with Alzheimer's dementia in addition to the memory decline. So this is a very pure Alzheimer's dementia progression. Remember, I did mention that it's probably thought that most dementias that we see are mixed dementia, which means you may not see this exact progression because there's another pathology at play. Next slide, please. So how do we manage dementia? This is, I think, the most important thing that we talk about in our clinic. The diagnosis is really just a very small part of it. The most important thing is how do you live with the diagnosis? Next slide, please. So, unfortunately, there is no cure for dementia. I like to tell my patients that people way smarter than me are working on this every day. I hope I get to see a cure in my lifetime. But yeah, we don't currently have a cure for this. What we do have are ways to enhance someone's quality of life, maximize their functional performance, try to stabilize cognition, mood, and behavior. Because if someone does have a diagnosis of any of the types of dementias that we talked about, what we want them to be able to do is live life as safely and as happily as possible. We want them to be able to continue at the baseline that they're at as long as possible. If it's possible for them to stay in their home, that's what we want. We want them to still be able to enjoy life. So a lot of the things that we're recommending and we're talking about in the clinic are geared at that. Next slide, please. So some of the non-medication ways that we manage dementia, cognitive training, the data is really inconclusive on that. There may be some short-term benefit to it, but I always tell my patients, it never hurts to use your brain. So, nothing wrong with doing some cognitive training. Supportive individual and group therapy. This could be for the patient, but oftentimes we see that more for caregivers. Caregivers have a high rate of burnout. It's very stressful to care for someone who has memory loss, and oftentimes support groups where you just know you're not alone. You can talk to other people who have gone through the same thing. You can get suggestions and tips from someone else. That can be very helpful for our caregivers. Physical and mental activity. What we saw in COVID is that our patients with dementia, who were isolated because of the pandemic, couldn't get out, they weren't really socializing, they had a much faster decline in the progression of their dementia. And what we know is socialization is very helpful for kind of maintaining someone's cognitive status as long as possible. So encouraging someone to still get physical and mental activity, learn something new, learn an instrument, try to crochet, knit, something that's new that makes your brain have to kind of work a little harder. And then family education and caregiver support is huge. How you communicate with someone who has dementia is different than how you communicated with them before they got diagnosed. And sometimes that can be incredibly frustrating to have someone ask you something that you just answered 2 minutes ago, and again in a minute, and again in a minute, and again in a minute. But it's important to be patient and understand that this is not something that the individual is doing on purpose. So helping our caregivers understand that, I think, goes a long way towards helping them kind of process and be able to deal with the diagnosis. And then safety. We talked about making sure that there are no weapons in the home. Another risk is someone may get out of the house and get lost, or there may be problems with driving. So now that we have a diagnosis, we want to make our caregivers and family aware of the safety risks that are there and make sure that we address those. Next slide, please. We may need to modify the environment. For instance, if we have someone that really likes to just go for a stroll at 7 o'clock at night when the sun's down, we may just have to find a way to alarm the door. So at least somebody knows if they go out and there's not a concern that you wake up in the morning and, oh my goodness, where is mom? And then structure activities to match what the person is able to do. It's not uncommon for me to sometimes see caregivers who want to kind of train the person back into normal cognition, right? So they're like, oh, I make them do 1,000-piece jigsaw puzzles, and we're doing Sudoku every day. That's going to be frustrating for someone who's got memory loss if it's beyond what they can cognitively do. So tailor the activities to what they're able to do. We can't reverse it, we can't cure it, but we can make sure that the person feels whole and respected and loved in the process. Next slide, please. In our clinic, we like to talk about the 5 M's, and these are the areas that we tell caregivers, make sure that these are shored up, make sure that you have the right control over this, because these are areas that can be in jeopardy when someone has a diagnosis of dementia. So, money. Someone with dementia is at a higher risk of being scammed out of their money. I have had patients that have lost just ridiculous amounts of money to scams because they did not have the executive function to be able to realize that it was a scam. So we tell families, make sure that you're on the bank account, right? That you're on the online account, that you can see how the money's being spent, that you can, access it if you need to protect this person from fraud. Meals. Depending on the stage of dementia, some people may actually either eat too much because they just don't remember that they already ate, or not eat because the part of their brain that stimulates hunger is damaged. So a lot of times I'll see patients too that are losing weight because nobody realizes that they're at the stage now where they're not going to prompt themselves to eat. Someone is going to have to tell them to eat or sit down and eat a meal with them. And they may say, I'm not hungry, but then you put the food in front of them and they eat the whole plate. So we like to cue caregivers to be aware of that and realize that they may need to kind of have more supervision with meals. Mobility, there's an increased risk of falling with dementia. Someone may forget to take their medications or do not remember that they took them and double up on their doses. And then medical care. They may not remember if the doctor changed a medication when they went to the last appointment because they don't remember the last appointment. So these are the areas that we like families to be aware of and make sure that they kind of step in and implement some supervision. Next slide, please. I'll just touch on this briefly. making sure that the healthcare system knows your wishes for the future. Do you want CPR in the event that you lose a pulse? Do you not want CPR? Are you okay being on a ventilator for a prolonged period of time? Are you okay having a tube that puts food into your stomach if you need it? Those are things that should be filled out. Your primary care doctor should be talking to you about that. And then the healthcare power of attorney form is how you get to pick who makes decisions for you when you can't. And I encourage people to do this when it's not an emergency. Do this when everything is fine. Because it's really challenging to be in an emergency situation and realize there isn't a designated decision maker and someone has like 7 kids. Because the state of Ohio says they all have to agree on the medical decisions that are being made for that person, which can be very challenging. I would also say our patients who we diagnose with dementia, if they are somebody else's healthcare power of attorney, we encourage them to maybe give that up and let somebody else be named in that role, because they've just been diagnosed with a progressive memory disorder that is going to continue to decline, which would put them in a position of not being able to serve as a power of attorney for someone at some point in the future. Next slide, please. Prevention. Next slide. Oh, it's so tiny still. So this is a journal article. This is a figure that looks at some of the modifiable risk factors for dementia. And it looks like if we address this, we can decrease the risk of dementia by this much %. So we know that patients who have less education earlier in life are at an increased risk of dementia, so that's a modifiable risk factor. Hearing loss is a modifiable risk factor. Traumatic brain injury, I wouldn't say it's modifiable. It does increase, if you have a traumatic brain injury, it does increase the risk of kind of having earlier onset of symptoms of dementia. I would say how we modify that risk is making sure that we're doing a lot of fall precaution, safety around that. Hypertension, that's a modifiable risk factor. Alcohol is a modifiable risk factor. Obesity is a modifiable risk factor, as is smoking, depression, social isolation, physical inactivity, air pollution. I think that's an aspirational one for modifiable. That's really not in anybody's control, but it is potentially a risk factor. And then diabetes. But when we add up all these modifiable risk factors, what we see is that accounts for maybe 40% of what we see with dementia. There's still 60% risk that we really don't know what that is. So there's still things that we don't know about dementia, still things that we're learning, but it makes a lot of sense to still attack these things that we can change, that we can modify when we're working with patients. Next slide, please. So we saw obesity as one of the modifiable risk factors. So physical activity is great for everybody. It helps prevent falls, which could prevent a traumatic brain injury, which was another modifiable risk factor. Helps maintain mobility, increases bone density, reduces risk of fractures, and reduces death rates. Next slide, please. So the American Heart Association, I believe, recommends about 150 minutes of moderate intensity aerobic activity a week, and that can be broken up into smaller increments of time if need be. Next slide, please. So that could be anything. Gardening, wheeling a wheelchair, walking quickly, using the stairs, those all count as moderate aerobic activities. And then high intensity aerobic activity could be jogging, playing tennis, walking uphill. Next slide, please. And then nutrition. I tell my patients that the things that keep their heart healthy are also good for their brain, right? So we tell all of our patients who have heart disease and our patients who don't want to have heart disease to eat a diet that's rich in brightly colored fruits and vegetables, low in saturated fats, rich in whole grains. And I tell my patients who have dementia or who are not wanting to progress to dementia the same thing. It's not a miracle cure. People may still get dementia even if they're eating well. But again, it can't hurt to have your body in the best shape possible if you are genetically predisposed to develop dementia. Next slide, please. Next slide, please. And drink water. Stay hydrated. Dehydration for someone who has dementia really can worsen their cognition. We see many patients come into the hospital and families tell us, oh my goodness, they got very, very confused And then we do some labs and we find out where they weren't drinking enough water. So making sure that you stay hydrated is helpful. Making sure that your loved one with memory loss stays hydrated is helpful. And again, back to that, people with dementia may sometimes forget to eat. They may also sometimes forget to hydrate themselves. So even if you just have to kind of walk by every 15 minutes and just say, hey, Mom, take a sip. And she takes like one small sip. It's the same thing we tell pediatric patients, their parents, small, frequent sips. It's still hydration. It's still going to work. You just may have to do it more frequently. So same thing with someone who has dementia. Next slide, please. Again, traumatic brain injury is a modifiable risk factor. So addressing fall risks in our patients is very important. So each year, 3 million older adults go to the emergency room for a fall, and they are the leading cause of injuries in older adults. So making sure that we're modifying that risk is helpful. Kara, how easy is it to get a home safety evaluation from physical therapy? Is that a thing, or do we just tell patients that and then you guys are like, nah? Huh? Through a home health? Okay. Okay, that's good to know. She said you might be able to through home health, and I'm guessing what she means is if someone has home health and has physical therapy and occupational therapy coming out to their home, those therapists may also be able to do an assessment of the home while they're there and look for things like throw rugs, bathrooms that don't have grab bars, risks of falling in the home, and make recommendations that can help reduce the risk of falling. Next slide, please. We talked about the fact that dementia is a risk for fall, as is getting older, as is arthritis and dizziness and loose carpets, poor lighting, dehydration. All of these things do kind of all tie together. Next slide, please. And one more slide. Next slide, sorry. I had a lot on falls. Okay, next slide. And then driving. Back to the whole, would you let the grandchildren drive? If you're a caregiver for someone who has dementia, ride along with them every so often, right? Cars are dangerous. Cars are weapons. And what you don't want is to potentially lose your loved one in a car accident because they shouldn't probably have been driving at the stage that they were cognitively, or for someone else to get hurt also. So again, if you're a caregiver and you have someone that you're caring for that has dementia, do a ride along every so often, just to kind of see that, they're still following the rules of the road. It still makes sense to let them drive. For our patients who are at the point where they cannot safely drive anymore, we have a couple of options. We have occupational therapists at SUMA that do driving assessments, and they do various tests looking at simulating different conditions on the road. They also test reaction time, and they can let us know if someone is appropriate to still drive. Sometimes what they'll do is they'll send them for an on-the-road test, and then we'll get that information back. Some people refuse to stop driving. So for those patients, we do tell families, do whatever you can to disable the car, hide the keys. I know it sounds terrible, but it's a safety precaution. And then we can also send a letter to the Bureau of Motor Vehicles and tell them that this person is a danger on the road. And what happens then is the Bureau of Motor Vehicles will send a letter to the patient that they have 30 days to get back to the BMV. And that letter has to go to their doctor, and the doctor can tell the BMV that I think this person should stop driving immediately because of this diagnosis, or I think they should at least have the driving test, the full driving test or the partial driving test. There are a lot of options there. However, if the person does not get the letter back to the BMV in 30 days, their license is automatically suspended. It's a medical suspension. We don't like to go that way if we can avoid it, but sometimes we can avoid it. The other way is that, if someone agrees that they're done driving, it's not safe anymore, you can just have them go to the Bureau of Motor Vehicles and they can exchange their driver's license for a state ID card. So they'll still have identification, they just won't be able to drive with it. Next slide, please. I always like to throw this in there. I don't know that there are any studies saying that being grateful changes anything about dementia, but being grateful, I think, helps us as Christians remember what God has done for us. And I have to believe that spending time with God is beneficial for anybody who's dealing with memory loss, right? Spending time with the creator of our brains, who understands every neuron, even when they're broken, even when they have abnormal proteins on them. I would encourage all of my patients to do that, regardless of stage if they can. Stay in contact with God. Be grateful for the blessings that He's given you. Pray without ceasing. Bring them to church. I know it may be challenging as a caregiver, but this is a social environment. This is actually really good for someone who has dementia. Next slide. So frequently asked questions. I know there will be questions, but I thought I would try to tackle some of the ones that I usually get when I'm seeing patients. So what is the difference between Alzheimer's and dementia? I get that pretty frequently, like, okay, she has dementia, but it's not Alzheimer's. So that goes back to that umbrella picture that we had, right? That dementia is the overarching generic general term, and Alzheimer's is a type of dementia. So all dementia is not Alzheimer's, but all Alzheimer's is dementia. That's usually what I tell my patients. There's a little more nuance to that, but for the purposes of today, that's what it is. Do cholesterol medications cause dementia? I get this one a lot. It's inconclusive. There have been studies looking at that, and studies that have said, like, oh, we took patients off of cholesterol medication and their memory got better, but it is inconclusive. And I will say that if I have to choose between some data that's inconclusive and not protecting my patient against having a stroke, which can be devastating and can cause truly devastating memory loss, I'm probably going to err on the side of protecting them from having a stroke. Next question. Are there any supplements that can prevent or cure dementia? The short answer is no. People are always looking at this yearly. There's research around this, looking at things like ginkgo biloba. There's no evidence to support that. Omega-3 is not really any evidence to support that. We were talking about hormones, Dr. Ganta. There's no evidence to support that. Currently, again, I think the best that we have is exercising, keeping yourself as healthy as possible, socializing, continuing to use your brain. I also get a lot of questions about Prevagen. I think it's just really expensive jellyfish extract. And I think it probably would be prescription if it was actually very, very effective for memory. But I have people that swear by it. Placebo effect is real. So if someone is taking it and they feel like it's benefiting them, I don't really fight them about it. But it's not something that I recommend or encourage that my patients go take. Next slide, please. What is my risk of developing dementia if I have a relative who has dementia? So that's a really big question that I get from a lot of patients. Specifically Alzheimer's dementia, there is a genetic component. The biggest risk factor for Alzheimer's is getting older. So every birthday, your risk of developing Alzheimer's goes up just a little bit more because age is the biggest risk factor. But genetics is also a risk factor. So if you have someone in your family, like a first-degree relative, so your parents or your sisters that have had Alzheimer's, there's studies that show that by 90 years of age, nearly half of the people with a first-degree relative will have Alzheimer's themselves. So there is a genetic risk there. It's another reason that family history is important. My grandmother had Alzheimer's, and several of my great aunts and one uncle have Alzheimer's, so I have a higher risk genetically than probably the average person that doesn't have a family history. So knowing the family history is important. How long does my loved one have if they're diagnosed with dementia? I think that goes back to that no two people progress the exact same way with dementia. Really, I'd say Alzheimer's is the primary one that we have some specific numbers around, but usually we say the course of disease is anywhere from 8 to 10 years from the time of diagnosis. But what I also tell people is, don't wait for the other shoe to drop, right? Don't just sit around waiting for the bad part of dementia. Live life. Enjoy life. The part of the brain that holds memory is separate from the part of the brain that holds emotion. So sometimes long after a memory is gone, the emotion is still there. So I tell my caregivers and my patients, build happy memories, because those feelings may still be there even after the memory that they're attached to is gone. You can go past those, Bob, sorry. Next one. And one more. And one more. So in summary, some of the things I just wanted to recap. Dementia is not inherent to normal aging. And I say that because I don't want anyone to underestimate memory loss and just assume, oh, this just happens because I had a birthday. If you're having memory loss, please go to your doctor, get assessed, or have your doctor refer you to a professional like Dr. Ganta or myself who can do an assessment, but do not assume that it's just normal aging, because dementia is not inherently normal for getting older. The impact of dementia is far-reaching, extending beyond patients to caregivers in the healthcare system. If you know a caregiver, give them some support. They may just need like a hug, they may need a phone call, if they maybe even need you to come and sit with their loved one so they can just have a moment to go take a break, find a way to support them. Caregivers deal with a lot. They are doing a labor of love, but it's not easy. I often tell people, the more you love someone, the harder this is for you. So if you know someone who's dealing with this, find a way to support them. There's currently no cure for dementia. I am wrong. The cure for dementia is heaven. But there's currently no earthly cure for dementia. And then follow a healthy lifestyle and get regular aerobic exercise. There is nothing, no diagnosis, dementia, nothing that won't make better. Right? I never have a patient that I'm like, you shouldn't exercise. Everybody should exercise and eat a healthy diet. And last slide. Like I said, the cure for everything is heaven. I like to end with just a reminder for all of us that one day we don't have to worry about abnormal proteins in our brain. And those of us that have lost people to dementia will one day see them again. Then I, John, saw the holy city, New Jerusalem, coming down out of the heaven from God, prepared as a bride adorned for her husband. And I heard a loud voice from heaven saying, behold, the tabernacle of God is with men, and he will dwell with them. And they shall be his people. God himself will be with them and be their God. And God will wipe away every tear from their eyes. There shall be no more death, nor sorrow, nor crying. There shall be no more pain, for the former things have passed away. I'm so sorry for getting emotional. Very sweet. Thank you. It's easy to do a job day in and day out. And you kind of become a little bit like a worker in a factory, right? You're just going. And I think just talking about this for the last hour and some minutes just made me realize that it's not easy, because we see people in pain. We see people that are living with a diagnosis that I can't change. I can't cure it. I can just try to make their life a little bit better while they're going through that diagnosis. So just remembering that one day I will be out of a job is really helpful. So again, I apologize for the tears. So thank you for your time and your patience. Any questions that I did not cover in the frequently asked questions section? Yes.
I have a question about, when you say, first of all, I love your tears. That just touches my heart so much. So thank you. Because that just tells me you really care about what you do. And that matters.
Yeah. Thank you.
I have a question. You said basically, forgetting things is not, forgetting things is not a normal part of aging?
Dementia is not a normal part of aging.
Okay.
There is some memory loss that can be normal with getting older, but you won't know unless you actually get it assessed.
Oh, okay.
Yeah, so don't assume.
Assessment is the key.
Yes,
Okay.
yes. And paying attention to function, right? Normal aging memory loss should not cause an impairment in function. Impairment in function, we now get worried about dementia.
Okay.
Anybody else? Yeah, Christine.
So I'm wondering specifically about vascular dementia, because right before my dad died, he had that diagnosis. And I'm wondering, is that more of a lifestyle thing or a hereditary thing?
That's a great question, Christine. It's more of a lifestyle thing. So your dad having vascular dementia doesn't necessarily increase your risk unless you have the same stroke risk factors that he had.
Well, he had a bunch of strokes. So is that something that's hereditary or not?
It depends on why he had the strokes. There are a lot of different reasons that people have strokes. Sometimes they have an irregular rhythm called atrial fibrillation, and that can actually cause little clots of blood to shoot to an artery in the brain and cut off blood supply. Sometimes a cholesterol plaque in that artery can burst open and cause a clot to form over that area and block blood supply. I'd say the hereditary potential is more rare. Any of the other doctors in the room are welcome to jump in, but I'd say the fact that he has vascular dementia doesn't necessarily mean that you have an increased risk as long as you are maintaining a healthy weight, blood pressure, blood sugar, cholesterol. Yeah.
Thank you.
You're welcome.
He had diabetes for several years. Now, he had improved his lifestyle and reversed his diabetes, but he had been diabetic for several years.
Okay. And that is a big risk factor for stroke. Yeah.
Okay, thank you. I have one other question that you probably answered, but those abnormal proteins, does anybody know what causes those at all?
I don't think we do, actually. We know that it happens. Some people are genetically, they have the gene for it, and that's what we know. There are some genes that are more, people are more at risk if they have those genes for Alzheimer's, but there's still so much research going into those proteins. And it's interesting that even with the medication that Dr. Ganta mentioned, the Leqembi is one of them that actually attacks those proteins, it's still only giving us 4 months of slowed progression in a mild case in the span of a year and a half, which makes me think there's probably so much more nuanced pathology in Alzheimer's dementia specifically that we just still have not been able to target with any kind of treatment or therapy.
Thank you.
Yes, Pastor.
Anyway,
Sorry, yes, Jim.
on a real extreme situation, Jacob disease, mad cow that used to be causing people's brains to go berserk.
Yeah.
Is that kind of like just something from the 90s, or do you ever see that very often?
That's a great question. I've definitely been in the hospital and seen signs on doors like isolation, Creutzfeldt-Jakob, testing in progress, but it's never been positive. In my career, I've not ever seen anyone with that. Diagnosis, Dr. Ganta, Dr. Rajan? Any Creutzfeldt-Jakob? Wow. It is a rapid progression of dementia. So usually dementia is not a rapid onset, but that is one that is a rapid onset and progression. I've not seen anybody in my career, but I don't know if anybody else has it. Thank you, Linda.
Since, I don't know if this is a good question or not, but since COVID-19, with the vaccines, has there been a noticeable increase in dementia?
Oh, that's a great question, and I'll be honest, I don't know, Pastor. I haven't looked at any of that data. I don't know.
Okay.
That is a good question. Yeah. Any other questions? Oh, yes.
You mentioned that dementia is a clinical diagnosis.
Yes.
Can you clarify what you mean by clinical diagnosis?
Yes, it means that one test is not the sole thing that we use to diagnose somebody, right? So there's not like a CAT scan that I can get and oh, their brain looks like this, they have dementia. I still need their functional status from family. I still need to talk to them and see how they're living. So it's a clinical diagnosis because there's no one test that says, yes, this is dementia.
So basically you look at everything and say, in my opinion, I think, in my professional medical opinion, I think this is dementia.
Thank you for adding professional medical opinion. Yes. Yes, that is exactly what we do. And again, like I said, I think we're getting closer to having a lot of really good lab tests and imaging that will be even more supportive of the diagnosis.
On another topic, a diagnosis of dementia or memory loss, from a few families that I know of, can sometimes be a freeing thing in some ways, because now you know that the person is not just being ornery.
Yes, that.
They're responsible.
Thank you for saying that. You are absolutely right. And we see that every day in our clinic. Sometimes it is just a release for a caregiver to know, I'm not crazy, right? Like, I really did see what I saw, and there's pathology to support it. And yes, to your point too, this is not someone doing something on purpose, right? They're not trying to antagonize me or just make my life miserable. There's really pathology here. Now, sometimes we have to remind people of that because they still feel like someone's doing it on purpose. But yes, a lot of caregivers have a great sense of relief just being able to put a label and a name to something that they've been seeing for months to years.
I got more questions.
I remember you from 2 years ago.
Personality and dementia. Okay, so I met a man who was in his 80s. When I met him, he was just deciding to put his wife into long-term care because he couldn't take care of her anymore. So she and I were not friends. You know, we didn't know each other, but I knew him. I became his friend. And I would go with him to visit his wife. And she was always very polite and a fine lady and all that. Another person, a family member, you know, she was, you know, at holidays, there were a lot of people in the house, and she was a very, again, very fine, polite woman, and it seemed like I could see on her face that she recognized that everybody belonged, but some of them were relatives by marriage and whatnot, and so just who they were, but she was always very polite as if you belonged there. What is the experience or whatnot with the effect on personality when somebody gets dementia?
That's a really good question, and it depends on the person. It goes back to that no two people progress necessarily the same way. And the type of dementia sometimes matters too. So frontal temporal dementia has specifically what we call a behavioral variant, and you can see some very challenging personalities with that. Sometimes in some of the other dementias, you do see a personality change. I have seen people that families are like, oh my goodness, they're so mean. They were never like this, and they're so mean. Conversely, there are people who were mean, and their personality changed with dementia is now they're nice. And families tell me, like, yeah, that's not normal. So it can go either way. Yes.
I have one last question. I'm specifically thinking about someone in particular. She stayed at my house, and she swore she saw something out in my backyard. Mm-hmm. So she was on medication, and that's, you know, we figured out that's probably what it was. But she also developed dementia later on, but she refused to believe it. She refused to accept it. What do you do in a case where people are like, I am fine, there is nothing wrong with me? How do you handle a situation like that?
Yeah, that's an excellent question. I see different people kind of sometimes attempt to, like, I just need them to know. But to your point, there are people that will never know that they have dementia. What I was taught is if you can't bring them into reality, you just go into their reality. You don't fight it. You know, you just, if they say there's squirrels on the backyard and it's the middle of December in Antarctica, then okay, there's squirrels in the backyard. But trying to pull that person into the reality of, yes, you have dementia, oftentimes can be more detrimental than helpful. It can cause them to become very frustrated. So you make sure that you're keeping them safe. You may just have to do some kind of things that they don't realize you're doing, but you don't challenge it. You just kind of let it ride. No, you're fine.
got another question. It seems that with some people, the dementia just progresses and gets worse, and with some people, they're demented even like 1 hour, and the next hour they're perfectly fine, or one day and the next day, or something like that. So, I mean, can you talk a little bit about that, and, or how to cope, or how people cope, or whatnot?
Oh, well, that's totally within the realm of possibility for someone to have some good days and some bad days. It's actually one of the specific questions we ask our caregivers when we're interviewing them in the clinic. Do they have some good days, some bad days? There are some dementias that actually are characterized by having an alternating kind of alertness, where like 1 hour they're like alert and awake, and then they're kind of sleepy and confused the next hour. How you deal with that as a caregiver, support groups, counseling, and I think also understanding that it's not necessarily abnormal. I would also say, though, making sure that there's not something that's triggering delirium, because sometimes that alternating like awareness can be someone who's delirious, which is not dementia. That's a sudden onset diagnosis because someone may have an infection or be constipated, unable to urinate. So making sure first and foremost that it really is dementia, not delirium, is the first thing. But then I think there's a lot of acceptance with being a caregiver, and it's easy for me to say as not a caregiver, but being able to just kind of accept it and go with the good days and the bad days is probably the best advice I can give.
Hi. My husband had vascular dementia, you know, like Christine said. And through the day, he was pretty much okay. Not completely, but pretty much okay. But when it came evening and nighttime, he had what we called sundowners, I guess. And that's when he would get bad. In fact, we read the Sabbath school lesson in the evening, and he started out, you know, if you was supposed to read 1 or 2 verses, he would just keep reading. And then he got to the point where he was having trouble finding it. Then he got to the point where he was saying somebody took his Bible and mixed it all up, and that's why he couldn't find it. But is there any connection with that and sleep apnea?
Oh, that's a great question. So untreated sleep apnea.
Because I noticed that he was having sleep apnea.
Yeah, untreated sleep apnea can actually increase your risk of having a stroke. So
he had numerous strokes. The doctor said he'd been having them for 8 or 10 years or more, which we didn't realize. We thought he was just losing it slowly.
Yeah.
You know, until the last, when he had a massive stroke and only lived a couple days.
I'm so sorry. But yes, there is kind of that indirect link to sleep apnea and strokes and dementia. Also, sleep apnea that's not treated can just by itself cause some problems concentrating throughout the day. So sometimes someone can look like they're having some changes in their cognition, and then we treat their sleep apnea and it gets a little better. Oh, cerebrospinal fluid. I was not supposed to use an acronym. I'm sorry, Christine.
Does amyloidosis have anything to do with, my oldest brother is being treated for that right now, and since you mentioned that amyloid's in the brain and everything like that, does that have anything to do with that?
Where is his amyloid?
It's in his blood.
Okay. There is a condition called cerebral amyloidosis, which is a buildup of amyloid in the brain that actually can be seen on imaging. And those patients are at a higher risk of having some bleeding into the brain, and they also can have episodes, they're called transient focal neurologic events, that look like strokes, but they aren't. So there is an amyloid pathology. What I don't know off the top of my head is, I believe it actually is separate from Alzheimer's. My notes. Oh, sure. Yeah. Absolutely. Yes, ma'am.
What is the age of your dementia patient, the youngest?
The youngest I saw in fellowship was in her 40s, but she was a unique case because she had Down syndrome. And patients with Down syndrome, the majority, a high percentage of them, will progress to early onset Alzheimer's just by virtue of having a diagnosis of Down syndrome. Outside of that, I'd say probably in my current practice, 60. Yeah, but I do feel like we've had some people that have started a little earlier. Yeah.
My friend said she and somebody who's like having symptoms at age of 57.
That's possible. Yeah, that is possible. Is that person getting evaluated?
Yeah.
Okay, good. No problem. Yes, indeed.
So if you go to your regular doctor and you tell them, I seem like I'm getting more forgetful, they give you the cognitive test where you draw the clock and they say that give you 3 minutes to remember, but then you're concentrating on remembering those 3 words so you always remember them. Anyway, but who is the next one you go to? It doesn't have to be a referral from your doctor.
It depends on the clinic. So our clinic at SUMA, the Senior Health Center, is actually, you can come with a referral, but people often just call us and make their own appointment, so you don't absolutely have to have a referral. So yeah, that's a great question. The test that you just mentioned is called the mini cog. It's a very short test. It's very quick and easy to do in the office. But to your point, you're a nurse, Cindy. What we do know is that people who are very, very educated, we saw that 7% of people, like that 7% on our risk factor slide of education early in life is actually protective or decreases the risk by 7%. What I'm trying to say is people who are very educated sometimes, I want to use the term maybe fly under the radar a little bit, because they've got this huge cognitive reserve. But what we do know is that when they finally are diagnosed, they seem to progress much more rapidly. The thought being that they probably at diagnosis are at a later stage than we realize because they had such a big cognitive reserve kind of allowing them to compensate for so long. Yes, sir.
I heard in a presentation a few years ago, the presenter said that a very early sign that you may get dementia 20 years from now is if you cannot start a new routine and keep it up. Any comments on that?
Oh, well, that doesn't bode well for people with ADD, does it? I don't know that it's that linear. I think there are a lot of factors that could contribute to not being able to keep a new routine. So I would not let anybody be panicked. If you're having trouble remembering to whatever your New Year's resolution was, that may not be a direct linear correlation, because there are a lot of things that could impact that. I've not heard that though. Our wonderful church does not have a clock. Can someone tell me what time it is? 10 after 7.
You've been going.
Okay, well,
You're good.
we will relinquish anybody who wants to go home. I'll be here for a few more minutes if you have any questions. Thank you so much for your time.
Gabrielle?
Well, thank you all for coming. That was good. And lots of good questions. I hope you remember everything. It's a lot of stuff to learn. Before we close, I want to just announce our next meeting is going to be May 17th at 5:30. Again, we have a speaker coming. We're going to be talking about diabetes. That is probably more, it probably hits a lot of people. So we have a speaker. We have 2 specialists trying to get them in. So invite your friends. We're going to be talking about diabetes and your health. Thank you, Dr. Ruff, for an awesome presentation. And I have to ask my questions. Let's see. I was thinking maybe I shouldn't because it's already late. I'll just ask this next. Next time we come, I'll ask the dementia question, so we'll see if we can retain that that information. Have a good night and see you guys next month. Yeah.
Don't forget to ask questions.